In 2017, Serena Williams gave birth to her daughter. By then, she had won 23 Grand Slam singles titles, more than any active player in the world. She had spent 2 decades ranked at or near number 1, earned hundreds of millions of dollars, and built a career that made her one of the most dominant athletes of all time. She had access to world-class healthcare, she had medical knowledge, and she had a documented history of blood clots. And still, with all this, she nearly died. After delivery, Williams began experiencing shortness of breath. Recognizing the symptoms of a pulmonary embolism, she told the medical staff she needed a CT scan and blood thinners. Her concerns were initially dismissed. A nurse suggested that she was confused from pain medication and the scan was delayed. By the time testing was done, Williams had developed multiple pulmonary embolisms. If she had not continued to insist on further evaluation, the outcome would have been fatal. This was not the result of poor health, a lack of money, a lack of information, or negligence on her part. It occurred within one of the most technologically advanced healthcare systems in the world, where delayed response and failure to listen can still have life-threatening consequences. The United States spends more per person on healthcare than any other high-income nation. Despite that, it also has the highest maternal mortality rate among peer countries. Women in the United States are more likely to die from pregnancy-related causes than women in Canada, the United Kingdom, Germany, or Japan. And this gap is not evenly distributed. Black women in the US are approximately 3 times more likely to die from pregnancy-related causes than white women. This disparity holds across income and education levels and persists even among women with access to high-quality care. Public figures such as Serena Williams and Beyoncé, who has also spoken about severe pregnancy complications, are not exceptions to the pattern, they illustrate it. The difference is not biological. It reflects how medical systems assess risk, interpret symptoms, and allocate attention. Maternal death is often described as a single mistake in a single room, a misdiagnosis, a late call, or a clinician who didn't act fast enough. But in the US, the larger pattern isn't sudden error. It's timing, follow-through, and what happens after the patient leaves the hospital. The medical system treats birth like the endpoint. The body does not. According to the CDC, more than half of pregnancy-related deaths occur after delivery. Many happen days or weeks after birth when the patient is back at home, no longer under continuous medical supervision, and often no longer even seeing the same providers. Now place that next to how the care is actually organized. Postpartum follow-up in the US is often minimal and delayed. Many patients have a single scheduled visit weeks after birth, or none at all. Complications that develop in the meantime, for example, high blood pressure, infections, blood clots, cardiomyopathy, hemorrhaging, and severe depression, all can escalate quickly without monitoring. Insurance design makes this worse. For years, Medicaid pregnancy coverage in many states ended 60 days after birth, despite clear evidence that medical risk remains elevated for months. States have begun extended coverage to 12 months precisely because the old cutoff failed to match postpartum biology. What results isn't chaos, it's gaps. When a patient develops symptoms at home, she isn't being actively monitored. She may not have a visit scheduled, she may no longer be covered. She may not have transportation, childcare, or paid time off to seek help. This is what structural failure looks like. And as we touched upon earlier, those gaps don't affect everyone equally. In 2023, the CDC reported that Black women died at a rate of 50.3 deaths per 100,000 live births, compared with only 14.5 for white women. That number is easy to skim past, so here's what it actually means. For every 100,000 births, about 35 additional Black mothers die who would not have died if they experienced the same outcomes as white mothers. These are not rare medical flukes. These are excess deaths. The CDC also estimates that more than 80% of pregnancy-related deaths are preventable. Preventable does not mean that the patient failed. It means that there were multiple opportunities at the provider, facility, system, or community level where earlier recognition or treatment could have changed the outcome. Bias is one of the mechanisms that determines whether those opportunities are taken. Research consistently shows that Black women are more likely to have their pain minimized, their symptoms questioned, and their concerns delayed. When warning signs are second-guessed, treatment doesn't just slow, it often arrives too late. Serena Williams survived because she recognized danger and had the authority to insist on care. Many patients don't have that leverage. And to make matters worse, geography compounds the risk. About 35% of US counties are considered maternity care deserts, places with no hospitals offering obstetric services and no providers. More than 2.3 million women of reproductive age live in these areas. At the same time, the share of hospitals without obstetric units has steadily increased over the past decade. So when complications arise, the question isn't only whether someone made the right call, It's whether there was anywhere to go, whether there was anyone available to listen, and whether help could arrive on time. Maternal mortality in the United States is best understood as a stress test of infrastructure, continuity of care, postpartum coverage, access to obstetric services, and whether the patient, especially Black women, are believed when they say something is wrong. Change comes from closing the gaps we already understand. Paid maternal leave so recovery isn't rushed, continuous care after patients leave the hospital, and access to obstetric services regardless of geography or race.